Hello, listeners. It's Trish Hammond here again. Yay! From Transforming Bodies. And today I am so freaking excited. I'm going to be speaking to the amazing Dr. David Amron. Now, Dr. Amron is like they call it different things in the US, but in Australia we say cosmetic dermatologist. I think it's the same thing. But Dr. Amron is actually a dermatological surgeon. Did I say that right?
You got it.
Yay.
Yes.
And
Dermatologic surgeon.
Yeah, awesome. And he practices all surgical and cosmetic procedures and has been doing so for 25, 26 years, and especially on liposuction. So we're going to be focusing today on lipedema because I know a lot of you people out there, including myself, do suffer from lipedema, and we get lots of inquiries, and it's all about bringing light and awareness to the disease and how he's basically a pioneer surgeon for it. So welcome, Dr. Amron.
Thank you, Trish. Glad to be here.
Yeah,
Good morning.
Thanks so much for joining us today. So first, before we start, I know I've kind of asked you this question, but how did you get into what you're doing? Like, first of all, what made you choose dermatologic, as your chosen field? And then how did you get into lipedema?
Yeah, well, choosing a field to specialize in was always a challenging thing. You know, there were those that went into medical school knowing they want to be an ophthalmologist or a OBGYN, and I actually thought I wanted to deliver babies to begin with. And in my first rotation after delivering 3, I decided it really wasn't for me. And then I had a hard time deciding what to go into. And not until really after medical school that I decided about dermatology. It just interested me. It treated a variety of patients. I did a 2-year research fellowship in it also. It's very competitive to get into. So I went into dermatology, and most people think dermatology is only treating rashes and acne and pimples, but it's more than that. We develop a lot of the cosmetic procedures like laser procedures, Botox, fillers, and something called tumescent liposuction was developed by a dermatologic surgeon like myself in the mid-1980s. So really, that way of doing lipo is in our area of specialization. And so when I went into practice, I began to do liposuction and had a sense that I was good at it. I was kind of mesmerized by it. It was a very unusual, different procedure, and I just took to it. I loved it. I loved the challenges of it, and I decided back then, over 25 years ago, to build my whole practice around lipo. And it got into doing a lot of stuff that people were not doing. I began to get referrals from doctors, complicated patients, revision patients, and then a lot of complicated areas that nobody was really doing, like calves and ankles and forearms and things like that. So that's how my whole expertise developed.
Well, it's really interesting you should say that as well, because, the difficult areas like the calves and ankles, like I've spoken to so many women in Australia that suffer from lipedema, and they pretty much, nearly all of them, travel overseas for the calves and ankles because it's such a fine niche area, and it's actually a really dangerous area as well, isn't it, if you don't know what you're doing?
Well, I think that's true. I mean, I think it's perceived as being very dangerous. I think most surgeons stay away from it for really no great reason, but I think it's having to know what they're doing and to develop an approach to this more challenging area. And it's something that just, again, I was enamored with years ago. Nobody was doing it 25 years ago. I was the only one really doing it.
Yeah.
And I had to develop and engineer a way of going about it. And whenever I'd seen calves and ankles done at all, it was done in a very piecemeal fashion with bits and pieces, and never done with the right type of understanding of what the shape you're creating. So I basically engineered and designed an approach to it that I really haven't changed, quite honestly, in over 25 years. And it involves doing the whole entire unit, where you're accessing it from, positioning of patients. We can start to talk about these things. But it's quite honestly, it's all about staying in that what I call the safe plane. And as long as you're in that safe plane, you are between the skin and the muscle, and you're never violating that plane. You're not getting into structures that can cause problems like clot formation, compartment syndrome with bleeding, damage to nerves, lymphatics, other things. You keep in that safe plane. It's all about orientation and how you're approaching it.
And so with lipedema then, like how do you even know that someone's got it? Like how do you diagnose it?
Yeah. So good question. It really is not that complicated if people begin to just understand some basic things about lipedema. And most of the patients I see by virtual consultations. They send photographs in, or we do Skype consultations where I'm looking at images of the patient. And even before I get on the phone with them, I'm seeing photographs and I'm able to say that person has lipedema or that person doesn't have lipedema. And so it's diagnosed basically clinically. There are no blood tests for it yet, even though we've discovered the gene for it. So it's a genetic condition. And it's diagnosed based on the signs and the symptoms. And the signs are a characteristic look to the legs and then the arms, where you get a circumferential distribution and more a column-like look to the legs from the groin area down to the ankles. Many times there's cuffing of the ankle area with the swelling and fat. And in those patients, the upper arms will begin to get involved years or decades later, and sometimes the forearms. And some people additionally have fullness in their upper buttock area, like a shelf there. So that's the way in which it looks. And then along with that, you get the characteristic symptoms, typically pain or sensitivity to pressure, swelling, easy bruisability, and the majority of patients will have hypermobility of their skin and joints that goes along with it, something called Ehlers-Danlos. So basically it's the signs and symptoms, but it's not that difficult. Even the layperson can diagnose it. In fact, most patients that come to me have not been diagnosed and quite honestly have self-diagnosed themselves by just going on the internet, understanding about the condition. Those light bulbs begin to go off and they say, I think I might have this condition.
Yeah, I totally agree with you. Tell me, what is hypermobility?
Hypermobility is increased flexion of joints. So typically patients can bend their fingers back more. They're more flexible than the average person. So that's hypermobility of joints, and it's called Ehlers-Danlos. And that's why I think that lipedema will eventually find to not just be a fat disorder, but it is very much a connective tissue disorder also.
Yeah. Well, I went to a conference in Australia once, and it's a conference put on by patients, and it's just the Lipedema Association. It's just amazing. Like it's a whole bunch of patients that just get together. And I had no idea that this was a disease as well. I thought it was just, people that were overweight, that lose weight. So it's the fact that like you said, it's a lot of people don't get diagnosed. It's true. They just come across something and they think, oh my God, I am really, I get a lot of pain when I get massaged or touched or bumped or whatever. And then it all starts to fall into place. So how can you, what's your technique? How do you help people?
Well, so I'm a surgeon for lipedema. So first of all, I would say that in terms of what patients can do, once they realize they have it or are diagnosed, that's why we need to be diagnosing patients much earlier. Quite honestly, pediatricians, OBGYNs should be diagnosing patients in puberty or the teenage years, because very quickly, if I can just take a second about lipedema, what it is, and then I'll go into how I go about treating it. So as many of you know, it's a fat storage disease, very under-recognized around the world, identified a long time ago at the Mayo Clinic in 1940, but just kind of ignored. And I think a lot of it's because we named it lipedema. That's how it's way too similar to lymphedema. It gets confused with it. It's genetically inherited. You pick up the gene from either mother or father's side, presents in puberty, always gets worse slowly, increases in activity with hormonal change of pregnancy, menopause, OBGYN surgery, has a characteristic look, which we talked about, and the characteristic symptoms of pain, sensitivity, swelling, easy bruisability. And it's not that complicated to diagnose, and patients should be diagnosed earlier, but there's things they can do preventatively to slow the progression before they need somebody like myself to do surgery on them. And those two things are pay attention to a respectful dietary strategy for lipedema itself. And there's a whole bunch of information on the internet about that, whether it's a ketogenic diet or a RAD diet, but generally avoiding gluten and things like that, and pay attention to swelling. If patients are swelling, get on compression garments or compression therapy. But yes, at some point, the only real way to so-called cure the disease or set it back to its infancy is to the liposuction surgery. And it really is very important, and it really is, it's transforming, it's life-altering for all the patients, both in terms of how they look and how they feel.
Yeah.
So do you want me to talk about my technique, how I go about things?
Yeah, because I was going to ask you, because you kind of pioneered tumescent liposuction, didn't you? And is that what, do you use that for, you know, lipedema, or I
Yeah,
kind of
well,
wanted to touch on that.
more than, and I've always said this, more than the tools, because there's so much emphasis on what tool a surgeon's using, whether it's laser or vaser or this or that. It's much more important the process of the surgeon, how they go about things, how they evaluate a person's body to begin with. So let me just start with that to begin with. You know,
Yeah.
even without lipedema, the way I address or assess somebody's body is to look at their entire body from a standpoint of balance and proportion. That is a very important thing. Liposuction, regardless of lipedema or not, should be reserved to create perfect balance or proportion. It's not about losing weight and getting in shape, as we all know. So that's the first thing, understanding a person's body and where to target and where not to target with liposuction. Then I talk a lot about something I call the cosmetic unit. What I mean by the cosmetic unit, which I've begun to pay more and more attention to, even though I developed this term, is when I do a cosmetic unit, such as the calves and ankles, or the thighs, or the torso. I many times will not just do parts of it, especially with lipedema. I do the entire thing circumferentially to create the right type of three-dimensional shape to that cosmetic unit. And a lot of the revision work that I do, even regardless of lipedema, I am addressing rebalancing not only a person's body, but that cosmetic unit, because it was done in not the right type of understanding of creating that right type of harmony. So, and that definitely applies to lipedema. When I do a cosmetic unit like the calves and ankles or the thighs, especially with lipedema, it's a circumferential disease. It wraps around entire cosmetic units. You want to follow that cosmetic unit to not only treat it completely, but to get the best cosmetic result with things. On to my technique. Just, can I get into that technique?
Yeah, please.
All right. So I strongly prefer to avoid general anesthesia for lipo. If you go back historically, lipo was basically been done, at least in the United States, by primarily two groups: plastic surgeons and derm surgeons like myself, dermatologic surgeons. Derm surgeons prefer approaching things what's called tumescent anesthesia by avoiding general anesthesia. Plastic surgeons generally prefer general anesthesia. Avoiding general is my preference, and I rarely use it. So I either do patients under twilight with an anesthesiologist, conscious sedation, or under local with mild sedation. And there are a number of advantages I've just got to talk about. Number one, it is safer, it is cleaner, but the most important thing when you're doing things like calves and ankles and cosmetic units in their entirety, it's virtually impossible under general anesthesia because you're dealing with the intubated patient lying there asleep in pretty much one position, being rolled around with flaccid, loose muscle tone. And it's almost impossible to stay in that perfect, safe plane with things. And the surgeon's in there either jabbing the skin from underneath, getting unevenness, or poking into things that shouldn't be poked into, like muscles or other things that can be more dangerous. So I prefer the approach of avoiding general anesthesia. Then in terms of my technique, which I talked about how I look at the body in its proportion and balance, I do cosmetic units in their entirety. I have a stepwise approach, the process. The first step is putting in the fluid called tumescent anesthesia. And it should be done completely and properly to not only completely numb, but to hydrodissect and to create a clean, bloodless field. That actually is a very important first step. The second step, I use a device called power-assisted liposuction. It's a vibrational device that is a very common tool of most surgeons. And it is very helpful in mechanically releasing the fibrous scar tissue that's part of lipedema. And it's done in the deeper plane as step 2. Step 3, I do like using a device called vaser, which is ultrasonic energy, to further emulsify the fat, to further release fibrosis. Step 4, I go back to the important fine sculpting with smaller cannulas. And then step 5, I may use an additional skin tightening step. In the United States, we have a device called Renuvian J plasma or radiofrequency body tight for maximal skin tightening. And that's the process. Each surgery, most patients with lipedema, the average get 2 surgeries for complete treatments. They are generally surgeries between 3 and 4 hours each. They are typically spaced between a week and a month apart in between surgeries.
Okay. Oh, I was going to ask you how long a procedure is. So generally you like to have one person, well, one area, 3 to 4 hours, and possibly like it's a split procedure. Like you get it done once and then you have it done
So yes, the average.
again.
So your average person with lipedema,
Yeah.
let's say, lipedema is divided into stages,
Yeah.
1 through 4. So let's say stage 2 or stage 3 patient,
Yep.
maybe even a stage 4 patient who has involvement in their entire leg unit from the groin down to the ankles, and has involvement of the arms circumferentially and maybe the forearms. They will be done as 2 surgeries, a month, typically a month apart. And the way I generally group things, I'll do the calf and ankle unit from the knee to the ankle along with the whole arm unit.
Mm-hmm.
And I'll do the thigh separately from the knee to the groin area all the way around. You have to divide it into at least that many surgeries for a number of reasons. Number one is the consideration of fat removal. We could talk about that. But more importantly, it's a lot to go through. Doing all that, the entire body is one surgery. It's too much in terms of lidocaine levels too, which is another discussion. You've got to keep your lidocaine levels at 55 milligrams per kilogram body weight or less. The fat removed per surgery in the United States, we have guidelines of 5 liters, but those are guidelines which most people should respect. But I have so much experience that I generally remove 6 to 7 liters on average per patient per surgery. Sometimes remove 10 or 11 liters per surgery.
Mm-hmm. Yeah, right. It's really, we have guidelines here as well. And ours is like, I mean, this is a few years ago when I did this research, but it's something like 2 liters, which is like,
That's
hello.
good.
I know, I could be wrong though, because I'm not a professional. But
I think you might want to, it's probably more like 4 or 5 liters.
Yeah, maybe. I just remember when I heard about it, I was like, whoa, it's such a different, with Australia and America. But so tell me, you've got like your experience with reverse liposuction procedures and correcting patients that have got surgery somewhere else incorrectly. Like I understand that that's quite a big part of your practice.
It is. It was for many years. It was the majority of my practice. About 2/3 of it was pure revision work. Now the majority is lipedema. Some of that lipedema is revision also, but I still do a lot of revision work.
Mm-hmm. Mm-hmm. Yeah, right. And yeah, because I think it's the important thing is about people going to the right person the first time. Hey, go to someone who just does it, because it's really hard to find that specialist anywhere in the world, really.
Yeah. The older I get, and I'm turning 60 in a couple months, I think like everything, it's hard to find that ideal person, whether it's a plumber or a contractor or an attorney or whatever it is, somebody to work on your car or a doctor. I mean, I think that it's important to take the time as a patient to do your research, to empower yourself with knowledge, and to make that right choice with things. That's why I'm just so incensed by a lot of the aggressive marketing tactics that go on to try to lure patients in. And that's just across the board with everything, even other cosmetic procedures, price-driven things. I did a radio show for 2 years in Los Angeles where I talked about concerning trends. And, I used to talk a lot about how to try to find the right surgeon. And I think that, take the time as a patient, do your research.
Yeah, that's so true. And I think what I'm finding nowadays, since what I think is happening lately, is surgeons, practitioners are choosing to specialize in, like a core amount of procedures, whereas the old days, you're like, yeah, no worries, I can do this, and this. And although you can, I think if you specialize in that, if you have something that you become famous or known for as your specialty, that's where it's better for the patient and it's better for you too, I think.
I agree. I think better for the patient and better for the surgeon too, quite honestly, to focus on one area and to really get it down and have the time and luxury to focus on that one area. And that's been a trend though, I think for many years. I was partners with Paul Nassif of the show Bosch. I don't know whether you get it in Australia.
Oh, we love it. I love him. Yeah, it's so good.
So Paul, Dr. Nassif and I were partners for 16 years. If you're watching, Paul, hello, Paul. But I told Paul years ago, just about 20 years ago, I said, Paul, really focus on one area. And that back then he really spent a lot of years focusing on the nose. I focused on liposuction, and I identified that trend years ago that patients will be, and rightfully so, should be really looking for that super specialist in individual areas. It's really hard to be great at everything. I got to tell you, all the surgeries are so different.
Yeah.
Breast surgery, from nose surgery to liposuction, they're such different procedures. Somebody can be great at one and not so great at another.
Yeah, that's so true. It's a bit like repetition is the mother of skill. 10,000 hours they reckon it takes to specialize in something.
That's true, right?
That's why my golf is so bad. But anyway, I was going to ask you as well. So, how did patients find you? Actually, before so that, do you have patients traveling from all around the world to come and see you?
Yeah.
Yeah.
So prior to COVID, about 15% of my practice was international from around the world. Only about 5 to 10% were within California. The remainder were from around the United States. But I've done patients from Nepal, South America, all throughout Europe, Alaska, Canada, Hong Kong, all over the place.
Yeah, right. So
with lipedema, actually Australia, a lot of patients from Australia.
Yeah. So if someone does want to come and see you, how long does it take? Realistically, how long does the whole process take from, even if it's just one area, or for someone to come and see, or have a consult online, come and see you, and have the treatment done? What's that time frame for recovery, and how long they have to be near you? Because obviously you can't just have surgery and disappear.
Yeah. So let's say they're coming for surgery. So the way the process goes with out of country patients, we do a virtual consultation, either by Skype or photographs and the telephone. I spend about half an hour on that consultation with the patient. Many times the family is involved too, and they're listening in, especially with lipedema, because they want to understand and involve themselves. In fact, I'd say with lipedema, a lot of the time, it's the patient's family or husband who have done the research, or sister, and actually found me through things. So the consultation is done, and then a treatment plan is developed by me, and then we plan and coordinate the surgery. So how it works is patients will obviously fly in. A lot of their paperwork and preliminary stuff like medical clearance is done in their home.
Mm-hmm.
They arrive the day before the surgery for the preoperative visit. I always want to meet the patient prior to the surgery, the day before, not the day of the surgery. They're required to come in. We do the preoperative visit, confirm what you plan on doing. The surgery is the next day. I prefer those patients that come with a companion if they are able to be within the few days in Los Angeles. The surgery is the next day. They go back to where they are staying with that responsible person, only if they have very complicated medical conditions. So I want them to go to an aftercare facility. They see me the next morning in my clinic for the postoperative check. They do 2 sessions of what's called MLD therapy, manual lymphatic drainage, with my therapist, especially for lipedema, the day after the surgery and 2 days after that. And they're then ready to fly back home 3 days after the surgery. Now that may come as a surprise to a lot of patients. Every surgeon will develop their protocols. This is my protocol for over 20 years. And it's extremely safe. I do have patients, especially with lipedema, on a regimen of something called Lovenox to prevent any chance of clot formation for 5 days after the surgery. Mm-hmm. They do wear a garment for 4 to 6 weeks, 24 hours a day, 4 to 6 weeks, 12 hours a day. Walking around, that's another important thing. I want patients walking the day of surgery and the day after. They start short walks. Now that's very important, the moving around, to help with the swelling and to prevent any chance of complications like clot formation. On the way home in the plane, even Australia, they're instructed every 2 hours to get up and take short walks.
Okay.
By the time they get home, they're able to resume most routine, normal activities. Lighter exercise and lighter work the first 2 or 3 weeks. They start seeing improvements in the first month, but it takes usually 6 or 12 months for the final improvements.
Amazing. And it's so funny because I was like, oh, I've got to ask this question. Then you answered them all the way through, because I was going to say, even if it takes 20 hours to fly to Australia, that's still going to be okay?
Yep.
Wow. Amazing.
Yeah, Hong Kong, Australia, Nepal, South Africa.
Yep. Amazing. So your practice, the the Roxbury Institute, what else do you focus on?
Yeah, so when Paul and I separated, it was 2015. We had a great relationship. I had a vision to create something a little bit different, and I felt again the industry was moving in much more of this, I don't know, at least in Beverly Hills, this Beverly Hills cliche of a cosmetic practice, and I wanted to create something that was different, something that was more structured, something that was a little bit more academic, and that was the birth vision of the Roxbury Institute, which is a larger center covering cosmetic medicine along with health and disease treatment in certain aspects, but with super specialists, not a jack of all trades. So I'm the founder and medical director. My practice is focused on all the aspects of liposuction and complicated liposuction. I have a director of facial plastic surgery, director of body plastic surgery, director of dermatology. We have cosmetic dentistry, Dr. Connolly in the practice, and we have Dr. Whitney doing naturopathic medicine. And it's really pretty amazing because it's great when we all work together on a patient, you know, and such amazing things come about. Even a few months ago, Dr. Whitney had a patient with mercury poisoning that was determined that it was from a filling in the patients. And she sent the patient to Dr. Connolly to remove the fillings. Many times Dr. Connolly, my dentist, will collaborate with Dr. Sykes, my facial plastic surgeon, on cases. But the whole thing is to be comprehensive in care, to be super specialists, but again, to be a little more sophisticated, be a little more academic, to sort of bridge that world between private practice and academic medicine, which is the birth of where we all came from. We came from hospitals where we all used to work together. And after you do all your training, you all disband and go set up your little private practice. I guess I'm trying to recreate that, working together where I came from.
Yeah, but you know, I absolutely love that because I think aesthetics, wellness, food, it all kind of fits together. And it, you know, like to me, something like I would absolutely be drawn to something like the Roxbury Institute for the simple reason that I do care about what I eat. I do care about the way I look. You know, to just go to one place and kind of get your, you know, stuff fixed. It just sounds perfect to me. Like it sounds like a natural progression as to where, you know, where people should be heading, because it is all one, you know, like no doubt about it.
I think the doctors really appreciate it too. You know, I've I guess attracted some really wonderful people. Dr. Sykes, did I lose you there?
No, I'm here.
I think I lost the screen.
No, I'm here. Oh, did you? I've got you.
Yeah. So Dr. Sykes is highly regarded, the chairman of the department at UC Davis, professor emeritus, president of American Society of Facial Plastics. So he's involved with us. Dr. Gabrielle Davis is my body plastic surgeon from Stanford, and she's amazing. And actually, she works alongside with me with my lipedema patients. So when I do procedures and they have a lot of looseness, they've just got too much looseness to tighten with the things that I do, I'll bring her aboard to do my arm lift and my thigh lift procedures along with me.
Yep, makes sense. It's a kind of it's a marriage that, you know, it all combines together.
Yep.
Oh, too, that's been
fun too. It's a lot more interesting. It's less lonely. I tell people whenever they come to work at the Roxbury Institute, there's two things you won't be. You won't be lonely, you won't be bored.
Yeah, that's exactly true, because it's like that. You go out there, you set up your flag, and then you're just waiting for people to come, and you're by yourself. It's really hard. Yeah, absolutely.
The energy is great around here.
Yeah, awesome. Before you go, can I just ask you to tell me, so apparently lipedema affects 11% of women worldwide. So it's pretty much only women, isn't it, that it affects?
Yes, that's correct. It pretty much affects only women. I've done 2 men with lipedema, but people should understand it is a genetic condition. It's what we call autosomal dominant.
Yeah.
So you pick up the gene from either the mother's side or the father's side, which means that 50% of the time, a patient is getting it from the father's side. So men are carrying the gene as frequently as women are carrying the gene. It's just not expressed as much in men as in women. So when you do a history on patients, you don't only just ask about the mother, you ask about the father and the females on his side, like his sisters or his mother, to try to find a family history for it.
Got it. Got it. And with that gene, it's not something that you can have a blood test for or a test for or anything. It's purely a physical diagnosis, yeah?
Correct. Not yet, and it's probably going to be years away till we ever have a diagnostic test for lipedema. It's really a clinical diagnosis. One thing I just want to just take a second to mention about because we were talking about liposuction and the removal of fat, and as people begin to understand what this disease is, it really is more than just fat, and it's more than just removing and sucking out fat. It's a process that's occurring in patients that goes on for years with chronic inflammation. And that chronic inflammation develops something called fibrosis. And fibrosis is a fancy term for scar tissue in that layer of fat. And that's playing a lot of havoc with things. As it develops more and more, it begins to affect other things and can eventually develop into something called lipolymphedema. So as the surgery is done, it's not only the goal to remove as much fat as possible, but to completely and properly decongest that tissue and remove all that fibrosis, which is scar tissue.
Yeah, right. I'll tell you, I just find this so interesting because it's so, like, although it's been years that you've been doing it, like, not many people actually really, like, there's still a lot of people that don't even know that this is something possibly they could be suffering from or can get fixed or anything.
It's crazy. It really is. And things are slowly changing, not really fast enough. But well, not only do patients not know about it, but most doctors don't know about it.
It's true too.
Now, quite honestly, probably maybe 5 to 10% at most of physicians truly know what lipedema is, probably more like 5%. And the ones that then kind of hear about it, they fall into two categories. Either they want to know more about it, which is really the way it should be, or they kind of poo-poo and say, oh, that just doesn't exist. If they didn't learn about it in medical school, which is just really, it's not being smart. It's really being ignorant. Ignorant, I don't mean by being stupid, but it's ignoring something. And that's the problem with lipedema. There's pervasive ignorance that goes on about it. The funny thing is, I did a consultation on a patient last week, and she was seen by a number of specialists at the Mayo Clinic. And she told them, I think I had lipedema. And they all said, I never heard of lipedema. And do you remember what I told you, that this condition was identified at the Mayo Clinic in 1940?
Yeah.
So here it is, the place that it was identified, they didn't even know about it. That's nuts.
Yeah. Yeah. So it's almost like it did a full circle. They learned it and then they unlearned it and then it came back. That's so good. Look, I reckon we've pretty much covered everything I could possibly out there. All I want to do is, like, when can I book in for a consult? Because my family does have this gene. There's no doubt about it. So it's just so interesting to know. Yeah, I love it.
It can be very subtle, I got to tell you. There's different stages, we say, and sometimes patients are just stage 1, or even I call them stage 0. They can be 115 pounds and triathletes and have almost perfect bodies, but they have subtle lipedema. So that's why people say, well, 11% of the population, that's 1 in 9 or 1 in 10 women, but there are a lot of women that have it that have very, very mild lipedema that it's easily missed with things. Yeah.
Look, I've got to say thank you so much for your time today. It's been so interesting.
My pleasure. Well, listen, thank you. I got to tell you, thank you, because thank you for doing this on lipedema and helping to increase the awareness of this misunderstood condition for patients.
Thank you so much. And if you don't mind, after I've done all this, I'm going to send it to the Association Society, wherever it's called in Australia, as well, because I think they'll love to put it on their Facebook page as well. Awesome. Thank you so much.
God bless. Be safe, everybody.
Thank you so much. So listeners, look, if you do want to get in touch with Dr. Amron, you can get in touch with him at the Roxbury Institute in Beverly Hills. If that's too hard as well, just send us an email to info@plasticsurgeryhub.com.au and I'll put you in touch as well. Thanks so much for joining us today. Bye. Bye.